In this video, we will discuss a case study of meningitis and example. Meningitis. The scenario is that about 19-year-old, a patient is come with the symptoms of severe headache, vomiting and photophobia to the hospital, and he is also unable to touch his chin to his knee. He doesn't have any rash, and he is alert and oriented. The general physician administered benzyl penicillin and transferred him to the ambulance and towards the hospital. His weight is about 70 kg, and these are some vital signs which are recorded at the time of the patient visit. Heart rate was 124 beats per minute, which is more or less very high. Temperature is elevated. Respiratory rate is also elevated, and blood pressure is low, and oxygen saturation found normal. Now there are some questions which have to be answered. First question is that what are the signs and symptoms of meningitis and meningococcal septicemia, bloodstream infection? Then the clinical signs of the meningitis include the classical triad of fever, stiff neck, and impaired consciousness found together in around 44% of the cases, while 90% of the patients with community acquired bacterial meningitis present with at least two of these four symptoms. It means if there is a presence of fever, neck stiffness, or altered mental state and headache, among these four, if any two type of symptoms are present, then these are the indicative of the meningitis. Three other classical signs of meningitis are the photophobia, vomiting, and rash. Additional signs and symptoms may include septicemia, which have the symptoms of severe pain and ache in limbs and joints, very cold hands and feet, shivering, rapid breathing, red or purple spots that do not fade under the pressure, which is called as non-blanching, diarrhea, and stomach cramp. Furthermore, physical examination should also include the testing of Kernicks and Budzinski sign. Kernicks sign is positive when the extension of knee produces a resistance or pain in the lower back or posterior thigh in a patient when the patient is lying in a supine position. While when passive neck flexion in a patient is present, producing a flexion of knees and hips, indicating the presence of Budzinski sign. Lumbar puncture is also considered as a mandatory test which is suspected bacterial meningitis, but this procedure is very dangerous and it can pose a risk of a brain herniation in patients with increased intracranial pressure. And in this case, imaging with computed tomography or MRI is recommended for the selected patient to detect brain shift. Patients who are also on immunocompromised state have a new onset of seizure, moderate to severe impairment of consciousness, or also not undergo lumbar puncture. Instead of they will go under CT scan or MRI. CSF concentration in CSF, white blood cell count are usually raised above 50 cells per millimeter in all cases of infective meningitis, up to 6,000 cells per millimeter in TB, and in case of viral meningitis it is up to 1,000 cells per millimeter, and in cryptococcal meningitis it is greater than 1,000 cells per millimeter in bacterial meningitis. However, lymphocytes predominate in tuberculosis, viral and cryptococcal meningitis, as well as early or partially treated bacterial meningitis. Polymorph nuclear leukocytes, that is immature and mature neutrophils, are usually predominantly present in case of bacterial meningitis. Proteins also usually range above 1 gram per liter in bacterial tuberculosis and cryptococcal meningitis, and above 0.5 gram per liter in viral meningitis. Glucose usually less than 50% in normally. The concentration of glucose is less than 50% of the blood glucose in bacterial tuberculosis and cryptococcal meningitis, but normal in viral meningitis. This is basically due to the impaired CNS glucose transport and consumption of glucose by microorganisms and neutrophils. Gram staining of CSF usually yields the organism that is mainly responsible for the meningitis, and in this case gram negative cocci is reported. What are important pathogens and appropriate treatment for the bacterial meningitis, including alternatives in penicillin allergy? The answer of this question is that the main organisms which are responsible to cause the bacterial meningitis is Neisseria meningitis, which is a gram-negative diplococcus, and after that Streptococcus pneumonia, which is a gram-positive streptococcus, is responsible for the occurrence of the meningitis. There are several serogroups of Neisseria meningitis, including A, B, C, and W135 and Y. However, a vaccine is produced against the strain of group C, which is also called as Men-C, and it is routinely scheduled and included to everyone under the age of 25. So, the incidence of the occurrence of the infection with this serogroup C has decreased markedly. However, there is no vaccine available for B group, that's why those persons which undergoes the vaccination plan still have the chance to get the meningitis again. As discussed earlier, benzylpenicillin should be immediately started prior the hospital transfer. So in this case, and if due to the increasing resistance to penicillin in pneumococci and H. the third generation cephalosporin, cefotaxime and ceftriaxone is currently recommended as the first line agent for hospitalized patient with suspected bacterial meningitis. However, for the confirmed meningococcal infection, the choice of drug in those patients which are allergic is chloramphenicol, and addition of ampicillin or amoxicillin is recommended in elderly patient that is over 55 years of their age to cover the listeria. Randomized clinical trials show that significant beneficial effects are found on dexamethasone on mortality and morbidity in pneumococcal meningitis, although no benefit was seen for the patient for the meningococcal meningitis. So, steroid treatment is also recommended routinely with or before the first dose of antibiotic, beyond which time dexamethasone begins to lose its effectiveness. Gentamicin does not penetrate the CNS to achieve therapeutically useful concentration, while ciprofloxacin is not effective against pneumonia. While among the carbapenems, meropenems achieve very good CNS penetration as compared to imipenem. While vancomycin has poor CNS penetration, however, it is prescribed routinely in countries with penicillin-resistant pneumonia, and it is also found very effective in treating the S pneumonia, but it is not found effective for Neisseria meningitis or Haemophilus influenza. What will be the pharmaceutical care plan for this patient? The clinician should review its decision to the use of for the use of the acyclovir. If HSV found culture sensitivity test is found negative, then the physician should stop the acyclovir. And if meningococcus is confirmed by the microbiology laboratory and antibiotic data sensitivity data suggests that the sensitive strain is bendipenicillin, then the very initial therapy should be continued. That is bendipenicillin 2.4 gram every 4 hours. However, it is very difficult once the patient is jump up to cephalosporin, it is very difficult to throw back it to the previous initial treatment if the patient shows the signs of improving. The duration of meningococcal meningitis is at least 5 to 7 days, and 10 to 14 days for pneumococcal meningitis, and at least 10 days for H. influenza meningitis. Steroid therapy should be continued for initial 4 days. Side by side, rifampicin 600 mg twice a day for 2 days should be administered in meningococcal or H. influenza meningitis who have not been treated with ceftriaxone as soon as they can tolerate the oral medication. Remember, all the previous medications are the IV medications. So, why rifampicin is must be prescribed to eradicate the nasal carriage of the organism found in the nose. Alternatively, ciprofloxacin 500 mg orally has been proven efficacy for eliminating the nasal carrying of the meningococcus only. What are the goals of the therapy in community-acquired bacterial meningitis? The goal is there to control the infection, stabilize the patient, and decrease the morbidity and mortality. And early recognize the septicemia and shock to permit timely intervention, including securing the airframe, administering high flow oxygen, and providing volume resuscitation, and identification of pathogen is very valuable for the treatment and diagnostic and the use of the antibiotics. But the delay of the antibiotics should not be delayed until lumbar puncture is an acutely ill patient. How should the therapy monitor? Patient should be closely monitored for the vital signs during the treatment or to ensure that the patient is responsive to the therapy. Serum C protein and white cell count should also be monitored, and repeated examination of CSF should be required during the therapy. What are the prognosis and potential long-term complications? Mortality rate is due to the Staphylococcus pneumonia and Neisseria meningitis is very high. That is 19 to 37% and up to 13% respectively. And these type of meningitis are followed by the neurological sequelae, including hearing loss, neurological deficit in the survivors, and these are very painful issues. Health workers and nurses, those who are have prolonged face-to-face contact with the patient, require prophylaxis, and prophylaxis also required for the close communities like nurseries, school, universities. In these public health sector, prophylaxis of the antibiotics should be provided. Smoking is also a risk factor for the carrying of the meningococcal bacteria, and the patient should be referred to stop smoking. I hope this video is very helpful, and this case study is very helpful to understand the meningitis. Thank you for watching. See you next time. Allah Hafiz. Assalamu alaikum. Bismillahirrahmanirrahim. Treatment of meningitis.